Do you have any of these following symptoms? Fatigue, headaches, hair loss, irritability, depression, decreased memory or poor concentration, low sex drive, easy weight gain, backache, joint aches, or poor sleep? Well, then you may have Syndrome X, a potentially serious medical illness that only I can diagnose or treat. Now, seriously, Syndrome X doesn't exist. But what we're going to talk about in this lecture are diagnoses themselves, the labels that we attach to signs and symptoms, to people with certain complaints. Now, the core myth of this lecture is that all diagnoses are the same and are equally valid, when the truth is that we arrive at these labels in very different ways. For example, there are some diagnoses which we would call a disease like diabetes, which is a pathological disorder where we can identify that there's something specific malfunctioning in some specific part of the body that is leading directly to these signs and symptoms that make up the diagnosis. We also may use the term disorder. Now, a disorder does not necessarily have any pathological change in any cells, but there is some problem with functioning that is identifiable. So an example of a disorder would be attention deficit and hyperactivity disorder. Versus a syndrome. A syndrome is a list of signs and symptoms that tend to occur together. It's a clinical syndrome, but it may not be one specific disease. It may be multiple things, for example. And amyotrophic lateral sclerosis, or ALS, Lou Gehrig's disease, something which I treat, is actually a clinical syndrome, not a specific diagnosis. It also is important to recognize that there are categories of diseases. Sometimes we may identify that a disease belongs to a certain category, like this is inflammatory versus nutritional versus degenerative, even though we can't get more specific than that. Now, this all relates to how doctors make diagnoses in the first place. What do they mean? How do we understand and use them in medical practice? Diseases tend to have a certain history over the course of our understanding of them. They generally begin as an identified clinical syndrome. We notice that different patients present with the same signs and symptoms that tend to have the same natural history, meaning they develop in the same way, they last for the same amount of time. This leads to the search for potential causes and risk factors that will make somebody more likely to get it than someone else, maybe particularly vulnerable populations or patterns of occurrence. And this is epidemiological data that gives us a lot of clues about what might be causing an identified syndrome. For example, if it's spreading like an infection, maybe it's an infectious organism that's causing it. And then, of course, we want to treat people. Ultimately, that's the goal of understanding illness, is to come up with treatments that are effective. And we don't want to wait until we understand every last thing about a disease or a disorder before we treat it. We try to treat it based upon sometimes just luck, just observing that some people do better with certain kinds of treatments. Or we try to understand based upon treatment trials. You may just try different treatments to see if they work. Let's try antibiotics. If it is an infection, then that should work, and it will also tell us something about what is causing it. There are multiple different ways also to treat a syndrome or a disorder, even before we completely understand its cause. So often people think only in terms of curing a disease, as if you can either only cure it or do nothing useful. In fact, most of what we do, most of what physicians do, is not directly geared towards curing a disease or a disorder. It is simply treating various aspects of it. So, for example, we may reduce the risk of developing a disease. We may slow its progression or even stop it from progressing. We may reverse some of the damage or disability that has resulted from the disease. We may alleviate symptoms and improve quality of life, prevent complications of the disease, or prolong survival with it. None of those things would be considered a cure, but they are all tremendously useful. But of course, we always want to understand as much as we can about the cause. Now, we use the technical term pathophysiology. That means everything about biologically what's happening with the disease. Like in diabetes, we know there are certain cells in the pancreas that produce insulin, and in type 1 diabetes, those cells are dying off. We know it's an autoimmune process that's killing off those cells. That's all the pathophysiology of type 1 diabetes. And we also, understanding pathophysiology is not all or nothing. It's not as if we know everything or we know nothing. Oftentimes, we deepen our understanding of a disease over time. We may at first realize that this is autoimmune, and then we may understand what part of the immune system is malfunctioning, and then what cells are being targeted, and the knowledge can get deeper and deeper. So we need to think of our knowledge about a disease as a spectrum, not an all or nothing thing. And further, one clinical syndrome may turn out to be many pathophysiological diseases, like the example of ALS that I gave before. It's almost certainly not one disease. It's probably 2, 3, or maybe even many. Let me go over a little bit the types of names that we use in describing diseases. We call this the disease nomenclature. It's the way in which we classify different diseases. Now, nomenclatures, they usually start off describing just the clinical presentation. We attach a name to one version of a presentation that looks one way and another version that looks a slightly different way. As we understand, however, the true underlying cause of the disease, the nomenclature is often completely rewritten. For example, the muscular dystrophies were first named based upon clinical syndrome, but then over the years we discovered specific genetic mutations that were causing specific muscular dystrophies, and the nomenclature had to change, and we renamed many of those diseases based upon the mutations, as opposed to just how it was presenting clinically. There are also different ways to make a diagnosis. There are what we call clinical diagnoses. A clinical diagnosis is based upon having a certain set of signs and symptoms. Symptoms are something the patient experiences. A sign is something you see when you examine a patient. There also are laboratory ways of either making or confirming a diagnosis. That means blood tests, X-rays, looking for anatomical or metabolic abnormalities. Oftentimes, these may make a specific diagnosis, or a diagnosis may be a laboratory finding, like if you have vitamin B12 deficiency, it's based entirely on having low vitamin B12 levels in the laboratory blood testing, and that going along with having the clinical symptoms that are caused by a B12 deficiency. There's also a special kind of laboratory test called a biopsy, where we take a piece of a tissue and we look at it under a microscope. And when a diagnosis is made entirely by biopsy, we often call that a pathological diagnosis. Some diagnoses are, the diagnosis is actually the name we give to a very specific pathological finding that you only see on a biopsy. And doctors sometimes make what we call a diagnosis of exclusion. You have an appropriate clinical syndrome, and we rule out everything else that can cause that syndrome, and what you're left with is the diagnosis of exclusion, something we know can cause those symptoms, but may not have any laboratory test to confirm it. We, for example, may diagnose patients with an Alzheimer's type dementia, which is a syndrome, not the disease Alzheimer's disease. Alzheimer's type dementia is what you have when you have dementia, chronic memory problems, and we ruled out all the treatable causes. What you're left with is the diagnosis of exclusion of Alzheimer's type dementia. Also, since we're talking about these diagnostic labels that we attach to patients, it's important to recognize that treatment is not necessarily intimately tied to those labels. It often is, but often it isn't, and that's important to recognize. The thresholds, if you will, for giving a treatment is not always the same as the threshold for making a specific diagnosis. And that could be either, the threshold could be higher or lower. In other words, I may give you a specific diagnosis, but you still don't meet the criteria for benefiting from a specific treatment. Or I may not be able to really definitively answer the question about whether or not you have a certain diagnosis, but you have enough findings that it's been demonstrated that you will do better long term if we give you a treatment. So the treatment is often evidence-based and a different consideration from whether or not we attach a certain label to a presentation. So that's an overview of how we think about diagnoses and how we use them clinically. There are many problematic diagnoses, however, that are out there, and they are different than diagnoses which are more clearly established, not controversial, and unambiguous. So here are some of the features that we have recognized to be wary of because they tend to occur with these problematic diagnoses. For example, they tend to be a clinical syndrome, not something that is tied to a specific laboratory finding. They tend to have common symptoms, symptoms that we call the symptoms of life. Anyone is likely to have them, like pain or poor sleep, or the list of symptoms I went over at the beginning of this lecture. Many of the symptoms are vague or non-specific, and this is a very important concept to understand. A specific symptom or sign is one that only one or a few or a narrow range of diseases will display. At one end of the spectrum, we have signs that are what we call pathognomonic. And that means that if you have that sign or symptom, then you have that one diagnosis because it's the only thing that causes it. If you have an acute Lyme infection, for example, you're 70% likely to have what we call a bullseye or targeted rash. If you have that targeted rash, you have Lyme disease because it's the only thing that causes it. At the other end of the spectrum are maximally non-specific symptoms like fatigue. Hundreds, thousands of different things can cause you to just have low energy, to be fatigued. Therefore, having fatigue doesn't really narrow the list of possible diagnoses very much. It's very non-specific. Problematic diagnoses also tend to be highly variable in their presentation. They don't have one very clearly identifiable natural history. And the symptoms and the signs that get attached to that diagnosis don't suggest one cohesive, coherent etiology. That's the fancy word for underlying cause. They have different symptoms that suggest different causes and don't all hang together. There's often also no clear pattern. Now, efforts to identify risk factors are not successful. They result in conflicting results or result in a pattern that is highly suggestive that these symptoms are due merely to stress or what we call a psychogenic illness. There also tends to be what we call diagnosis creep. Once you have a label, a questionable label based upon nonspecific symptoms without anything very objective to verify it, then it tends to apply to a greater and greater expanding list of presentations, a broader and broader scope. Eventually, almost anyone or any symptom can be blamed on this broad diagnosis. In addition, there's diagnosis expansion, and that means applying it to milder and milder versions. Maybe there are some diagnoses which are legitimate when they are applied to very specific, severe versions, but rather than broadening the application, it gets expanded to include milder and milder versions. So not everyone who's a little tired has chronic fatigue syndrome. Not every child who's a little overactive has ADHD. But that, again, is a tendency to happen over time. Sometimes that does legitimately happen because it's tied to better data collection. For example, the definition of hypertension was expanded because it was found that lower levels of hypertension, high blood pressure, did increase the risk of heart attacks and strokes. So it became more reasonable to include that in the definition. Now, treating these problematic illnesses when we have only a vague syndrome without anything specific to hang our hat on is also, of course, problematic. They tend to be resistant to very specific biological interventions. They tend to benefit only temporarily from treatments that are likely to have what we call a placebo effect or placebo effects, which is something I will get into much more detail in another lecture. They often respond to psychological interventions like stress reduction, and they appear to respond to a variety of treatments that don't have a common or plausible underlying mechanism. Now, I mentioned before about the pathophysiology of disease. While we don't need to fully understand the pathophysiology or all the things that cause a disease biologically, the more and more we investigate a disease, the more we should learn about its pathophysiology. We begin to get a little suspicious if the more we investigate a questionable diagnosis or a vague diagnosis, the less we seem to understand about the pathophysiology. If the people who are promoting the notion of this problematic diagnosis use what we call special pleading, they explain away all the lack of evidence that we would predict should be there if the disease had a specific biological cause, for example. And they use extreme speculation from preliminary or basic science, basically taking any little clue that crops up in preclinical or laboratory evidence, and then they extrapolate that wildly to making clinical claims. That's another red flag to watch out for. The practitioners who make a specialty out of treating these controversial or problematic diagnoses also tend to share a few features, and this should raise some red flags for you if you encounter them. One is that they often practice outside of the reach of regulation. They may have an offshore practice. Tijuana clinics are very popular because they're just across the border, but in Mexico where there are very, very lax regulations, so that's always a red flag. Often they have to fend off attempts to bring them within the standard of care, so they may be investigated by regulatory agencies for the quality of the care that they're delivering. They often will carve out special exceptions for their practices. They will sometimes use the political process in order to gain exemption from mechanisms that are meant to enforce a standard of care. They will often claim to be victims of a conspiracy, either of the medical establishment or the medical community, and that their ideas are being suppressed. And they will often use unproven diagnostic techniques in order to prove their diagnoses and follow up with unproven therapeutic interventions. So now, with that as a background, I'm going to turn to some specific examples that will illustrate a lot of the features that I just discussed. I'm going to start with a very controversial disorder, chronic Lyme disease. Now, Lyme disease itself is an infection caused by a bacterium, a spirochete, called Borrelia burgdorferi, and it is not controversial. It is a well-established pathophysiological infection. It is a real and serious illness. It was first identified in 1975 and named after Lyme, Connecticut, my backyard, where it was first discovered and is still endemic. However, we've now discovered several other species of Borrelia that can cause a Lyme infection syndrome, and it has been recognized in different parts of North America and in Europe. Now, Lyme disease has several different stages to it, like other spirochetes, like syphilis, for example. There is primary Lyme disease, which is the acute infection. There is also a secondary phase to Lyme disease where it's spreading throughout the body. It can go to the joints and the heart and the nerves, for example. It may cause a Bell's palsy or a facial paralysis. It may cause shooting pains in different nerves that are affected, and it may cause backaches, headaches, and joint stiffness. It can interfere with sleep and cause heart palpitations. And then there's the most serious version of Lyme disease called tertiary Lyme. This is a chronic Lyme infection, and Lyme has to go untreated or undertreated for a long period of time in order for this to occur, although tertiary Lyme will typically develop within 2 years of the initial infection. And the Lyme spirochete here will set up a chronic infection in the joints or in the nervous system. When it's in the nervous system, we may call it a neurolyme and can have symptoms of memory loss, spinal involvement, chronic meningitis. Now, because Lyme is a bacterial infection, it is treated with antibiotics. And antibiotics, several specific antibiotics, have activity against the Borrelia spirochete and work quite well. After a tick bite, before we even know there is an infection, there is evidence to show that a short course of oral doxycycline can reduce the risk of developing Lyme disease, so that's now standard practice. When an infection is documented to occur, a course of oral doxycycline, amoxicillin, or cefuroxime, these are just antibiotics that have activity against Borrelia burgdorferi, for example, for a few weeks is effective in completely eliminating either stage 1 or stage 2 infections. Now, if you have tertiary Lyme or neurolyme, then you need intravenous antibiotics for up to 6 weeks with either ceftriaxone or penicillin. That's a much more longer course with a more effective antibiotic that has good penetration into the nervous system in order to eradicate the infection. How do we diagnose Lyme? Well, it is based a lot on the clinical presentation. You have to have symptoms of an infection. The rash helps, but you don't need to have that rash. It's only present about 60 to 70% of the time. The confirmation is through blood tests. We look for antibodies, your immune system making antibodies against the bacteria, although they take time to occur. So an acute infection may occur before there's time for the antibodies to occur. We may need to retest in 6 or 8 weeks and then see the rising titers, as we call them, of the antibodies. The initial blood test is usually what's called an ELISA test, which is a screening test. And if that's positive, we can confirm it with a much more specific but involved test called a Western blot. So those are the two types of blood or spinal fluid tests that we would use. They have been shown to be very sensitive and very specific, again, when enough time has passed. The controversy comes in with the notion of chronic Lyme disease that is either present without ever having a documented primary infection, or that's a chronic infection that survives antibiotics. That's where we get into the controversy. These occur in various settings. For example, the etiology is often unclear, meaning that there was no documented infection. They may have nonspecific symptoms, and they may lack the symptoms that we ordinarily attach to Lyme disease. And we can't find a chronic infection. When we look at the blood, the ELISA or the Western blot, it's not there. Oftentimes, they don't respond as we would predict to treatment either. So there are many atypical features to people who present with chronic Lyme disease. Now, as I said, sometimes it occurs or the presentation or the claim is made for symptoms of chronic Lyme disease, again, this controversial entity, in people who never had Lyme disease and are presenting with a syndrome of nonspecific or vague symptoms. But sometimes it follows a documented Lyme infection, where someone is infected, they're treated, the infection itself is eradicated, but they have chronic symptoms following it. Now, in some cases, this may be due to, again, may be legitimate and due to the fact that there are chronic problems with immune activity. Sometimes the immune system can be activated from an infection, and you can have what's called a post-infectious syndrome. Or sometimes the infection itself may have done damage. If it did get into the nervous system, then it may have caused damage to the nervous system, and those symptoms are chronic. So the notion of having chronic symptoms of having had Lyme disease is not controversial, and that does sometimes occur. The real controversy is the notion that there's a chronic infection, an active infection, that evades detection and that evades treatment. In essence, you have to believe in an atypical Lyme disease that's seronegative, meaning the blood work is negative, and that's treatment resistant. That is a lot of what we call special pleading. What does the evidence show? If we look at the evidence, it does not support the notion that there's a chronic Lyme infection that survives adequate antibiotic treatment. Now, several studies of antibiotics in patients with symptoms that are often diagnosed as having chronic Lyme have also been looked at. In this case, we're not asking the question, do people have chronic Lyme infection? We're just asking, do they get better if we treat them with antibiotics? And there, the answer is clearly no. There have been several studies which show no benefit. Let's move on to another very controversial syndrome, chronic fatigue syndrome. In order to make the diagnosis of chronic fatigue syndrome, or CFS, you need to have chronic fatigue that lasts for more than 6 months without another documented cause, like multiple sclerosis or lupus, which are chronic diseases which can cause chronic fatigue by themselves. In many cases, it's therefore a diagnosis of exclusion. You have the fatigue, we've ruled out all other causes, so you're left with just this chronic fatigue. In some, a chronic infection with a virus has been documented, so we do have here a pathophysiological disease in some cases. The Epstein-Barr virus and other viruses have been implicated in some cases. However, in many cases, the diagnosis is questionable because there's no documented infection, or patients don't meet the strict criteria for the diagnosis. The risk here, if we prematurely apply the label of chronic fatigue syndrome to patients who have fatigue, is that we'll miss the real underlying cause. The Centers for Disease Control, the CDC, estimates that as many as 40% of the people who are diagnosed with chronic fatigue syndrome actually have a serious and treatable underlying disease that's being missed. So that's the danger of prematurely applying a label to someone. At times, the true underlying diagnosis may be socially or personally undesirable. For example, people may be chronically fatigued because they have a sleep disorder, or they may have a psychiatric disorder like depression and anxiety, but rather than accept that diagnosis, they search for another diagnosis that they would find more acceptable. Let's move to fibromyalgia. I encounter a lot of patients who walk into my office with a diagnosis of fibromyalgia, but what is it really? It does remain somewhat controversial. However, like chronic fatigue syndrome, there appears to be a vaguely but probably genuine pathophysiological disease that involves chronic low level of inflammation in the muscles and the fascia. The fascia is the connective tissue that surrounds the muscles. But in order to make the diagnosis, you have to have symptoms that last for 3 or more months, and you need to have specific tender points. There are 18 identified tender points on the body, and you need to have 11 of them. When you meet those full criteria, then it's reasonable to apply the diagnosis of fibromyalgia. It's still a clinical syndrome without a really well understood pathophysiology, but at least there are strict criteria so we can talk about it as an entity. However, most people who are walking around with the diagnosis of fibromyalgia don't meet those strict criteria. And the diagnosis is often applied to anyone who has chronic unexplained muscle pain or aches. Now, while the underlying cause is often not adequately assessed, that means, like with chronic fatigue syndrome, that can lead to missed diagnoses. For example, many people who are diagnosed as fibromyalgia have chronic sleep deprivation, and that diagnosis is missed because they're prematurely labeled with a vague or nonspecific diagnosis. They may also have chronic depression, or they may have something less specific diagnosis than fibromyalgia, just a myofascial pain syndrome, where we're beginning to get a handle on some of the underlying changes to the tissue that are causing those. But again, if you don't look for it because you've already settled prematurely on a vague diagnosis, you'll miss the opportunity to make a more useful diagnosis. But still, it exists as a syndrome, and for that reason it has been studied therapeutically, and there are actually 2 drugs on the market that are approved in the US by the FDA for the treatment of fibromyalgia, Cymbalta and Lyrica. Another syndrome which I don't think has a kernel of legitimacy to it is multiple chemical sensitivity. This is alleged to be a cumulative effect of exposure to toxins and chemicals in the environment. Symptoms do not follow any clear pathophysiology, however. There's no documented pathology. There's none of the effects that you would expect from any specific toxin or chemical. And this goes as far in some patients that they allege sensitivity to electromagnetic waves. However, studies have failed to find any consistent pattern or effect to either electromagnetic waves or, again, just a cumulative effect of chemicals in the environment. Another diagnosis similar to the multiple chemical sensitivity is Candida hypersensitivity. Now, Candida albicans is a fungus. It's very common. Many of us are colonized with it. It exists on our bodies, but not causing an infection. And it can cause infections. It usually crops up in the immunocompromised or people who are on antibiotics. However, there are those who think that chronic, undiagnosed, mysterious Candida infections can be responsible for an epidemic of symptoms such as fatigue, irritability, constipation, diarrhea. The list goes on. Again, all of the nonspecific and vague symptoms of life that tend to get attached to these vague syndromes. Now, Candida hypersensitivity exists in the absence of the expected signs of Candida infection or allergy. So the signs we expect to be there are not there. There's a claimed connection by some to multiple chemical sensitivity and also to causing diseases such as multiple sclerosis and chronic fatigue syndrome. But there's no evidence to support any of these connections. The notion of chronic Candida hypersensitivity was started largely by a Dr. C. Orion Truss in 1978, when he published his findings in a fringe journal, followed by a popular book. However, there was no evidence or research trail to back up his claims. It was really nothing more than pure speculation on the part of a single individual. The American Academy of Allergy, Asthma, and Immunology have come to their conclusion after reviewing all of the evidence regarding chronic Candida. And they concluded that it is speculative and unproven. Supposed symptoms are essentially universal, the symptoms of life. It results in the overuse of oral antifungal agents. While adverse effects from the oral antifungal agents are rare, they are inevitable. And the anecdotal experience is often misleading. In conclusion, I think we've covered a lot of information about what doctors think about when they're making a diagnosis. There are a lot of pitfalls, and it can often be very tricky to make an adequate diagnosis. The approach that we often take is to look for things that we know to treat, know how to treat, and know how to diagnose. All of the biological or serious entities that could plausibly cause the symptoms that a patient or a client is presenting with. If we make a diagnosis, then we treat based upon the diagnosis that we make. We find any contributing factors, we essentially treat what we find. But maybe we will rule out, we'll whittle away all of the known pathological contributors or causes of a disease, and we're left with a syndrome of symptoms without a clear biological cause. But we have ruled out anything serious or treatable. In that case, it's most effective to then shift our emphasis to treating the patient to improve their quality of life. And that is very, very important and should not be neglected. And we shouldn't get distracted from treating quality of life because of a search for a diagnosis that may not be there, or just for the false comfort of having a label to attach to symptoms.